So after the lot of philosophies since we are listening since morning, the different robotic systems, there's a lot of variations in the philosophies, the designs, implementations. One thing which remains common is a situation which can happen like this, called as an angry looking TKR, in spite of whatever system you have used, or whether it is a conventional surgery or a robotic surgery. So I think Dr. Jadhav has given an important topic to me to talk about. Once we see an angry looking post-operative wound, that is something which disturbs us maximally. And why it is important? Because there's an increasing number of volume of the TKR is happening. There's a early complication directly affects outcome. The infection remains still a major cause of early revision. It leads to the increased healthcare cost, and it impacts the quality of life of the patients. So angry knee is something what we call when there is a persistent pain, there is a stiffness, there is a redness, erythema around the operative site, and the painful range of motion is there, and which are seen particularly in the initial few weeks of the post-operative timings. You need to have a very high clinical suspicion when the patient complains of an acute onset of a pain, and there is a continuous and a progressive pain. Rather, there is a right from the post-operative period when there is no pain-free interval ever since the patient has got operated till that itself is a very common situation. If you try to dig out a history with the patient who develops a completely a PGI, and if you ask them, was there any time when you have a pain-free period? So most of the time we'll find out that the answer is no, there was no pain-free period. Right from the post-operative time, there was some other kind of pain was there. So that is one thing which should be considered very specifically. Discharge from the one side, sinus formations, and occasionally fever, which is not explained by any other reasons. This should lead to a very high level of suspicions. Now, in a post-operative period, there are certain red flags like an increased pain after the initial improvement. There is a persistent swelling and erythema around the operative site, and the new wound discharge or fever which is coming out. So any of these things happening around a post-operative zone, we should be very much careful for. Now let's see what are the couple of scenarios. Now a clinical scenario number one, patient is not having much of a symptom, subtle symptoms, 2 weeks post-op, stitches still in place, mild arrhythmia, no fever, and CRP which is mildly elevated as a post-operative period, which you will still find that the CRP is still on a higher side. Now this is something which is scary. You are confused whether the patient is getting infected or it is getting settled down. In this scenario, we really don't know in which way it is going to go. We tend to increase our level of antibiotics. So in such scenario, what we need to have is a very high level of suspicion is required, and keep a very close watch on the wound in which direction it is going. A scenario number two, where the patient is having effusion without fever. It's almost 4 weeks post-op. Pain, stiffness, there is effusion, some amount of erythema is there, and CBC, ESR, CRPs are at a borderline. So in such scenarios, it's always better to aspirate before and rule out an infection under a very sterile and aseptic situations. And a third scenario is something where you have an obvious infection, which is 3 to 4 weeks post-operative. There is a sinus, which with the discharging pus out of it, painful, swollen, febrile, and it is it's like a conclusive of having an acute prosthetic joint infection. Now this is how the normal knee look like, the wound, and the another one is an angry looking knee, which we really don't know in which scenario it is, depending upon the duration of the surgery. So one need to rule out certain conditions which can mimic like an infective or would be infective PGIs. The infective causes are acute prosthetic joint infection. There could be one superficial infection, or there could be a hematogenous seeding which is happening into the post-operative zone. Or there could be non-infective causes which are very important, like in presence of some hemarthrosis into the joint around in the joint, which is leading to the erythematous changes. Gout or pseudo-gout or the crystal arthropathy, what we call commonly, that also very commonly give you mimic like situation where you feel that it is like getting infected or something. Rarely, many of our patients, they do have a metal allergies, and if there is a CRPS kind of a syndrome. If you have to classify based on the timings, it's called as early infections. If it is less than 4 weeks, if it is between 4 weeks to 24 months, it is a delayed, and more than 2 years is a late infection. The risk factors we know, there's like diabetes, obesities, other comorbidities, long surgical time, OT disciplines, and if there are particularly some issue with the skin integrities. The initial workup involves mainly the blood investigations, which includes the baseline test like a CBC, CRPs, and ESR. The CRP should always be asked in a titer so that you can figure it out whether there is an uptrend or the downtrend to prognosticate about the outcome of the particular patient. The joint aspirate is subjected for the cell count and the percentage of the neutrophils specifically. It has to be subjected to gram stains and cultures, and the crystal analysis has to be done. Whenever you're doing an aspiration, make sure that there should be a proper antibiotic-free period of minimum 1 to 2 weeks, so that you can get a proper diagnosis in terms of getting the synovial cells and the WBC counts and everything. So multiple tissue cultures, it improves the yield. Biofilm organisms may require prolonged cultures. In terms of imaging, X-ray will show loosening periosteal direction only in the late cases, not at all in the acute scenarios. But ultrasound will be the investigation of choice to figure out how much is the fluid collection and what kind of an hyperechoic or the hypoechoic collection signals are seen. Nuclear scan can be considered, but it's an equivocal value. So the diagnostic threshold according to the MSIS criteria are that if the synovial WBC count is more than 3000, the polymorphonuclear percentage is more than 80%, and the CRP in titers is more than 10 milligram per liter, and the ESR is more than 30 millimeter per hour. If anything of this is positive, then we are dealing nothing but the PGI. And the initial management pathways depends, the strategy depends mainly on a clinical assessment. Avoid jumping on stepping up on an antibiotic or starting the antibiotic immediately. Investigate the patient based on the timing from the surgery. So if it is less than 4 weeks old, go for a diet that is a debridement, antibiotics, and implant retention. If in between more than 4 weeks and above, we can consider going for a revisions, maybe 1 stage, 2 stage, depending upon the multiple factors. And if it is if the things are negative, samples are negatives, then we can just think about monitoring it and conserving the things. In a diet, we all know the key steps are surgical debridement, poly exchange, lavage with antiseptic solutions, and IV antibiotics as per the culture sensitivity for minimum 4 to 6 weeks, along with maybe at times a chronic suppressive therapy. But when the diet fails, because of persistent infection or resistant organism or host factors like an immunocompromised situation, one need to consider a revision surgery in terms of stage 1 or 2 stage with the spacer and antibiotic loaded spacer period. Suppressive antibiotic therapy only for the non-operative cases or high risk cases, or the risk of resistance is there in that particular patients, we can consider going for a suppressive antibiotic therapy. This is atypical presentations in which is the gout or the crystal arthropathy is something which mimics maximally or very closely with the prosthetic joint infection, and it gives you is good enough to give you sleepless nights. Very common. It is typically mimics very closely with the PGI. There is a redness, erythema. If you do a blood levels also, you will see blood test. You will see that there is a leukocytosis. There is patient is having clinical fever and all. Everything which goes in more in a favor of PGI. But if you at that point of time you see a gout, investigate him for the crystal arthropathy. At times you will find a simple steroid dose or a colchicines will help you to reduce all the inflammatory actions immediately. CRPS also mimics in the similar way with the burning pain and stiffness. So post-treatment follow-ups is only mainly in terms of monitoring the CRPs, the symptoms, serial radiographs, and the return of the function to the patient. So the clinical pearls are, if there is an infection, the infection is a diagnosis of exclusion. The angry knee at 3 weeks, you need to highly suspect for PGI. Do not delay aspiration. Rule out the mimics, what we talk about, the crystal arthropathy. Earlier DIAR works best within 4 weeks. Always send for cultures and cell count, and prevention is always better than cure. So the take-home message is early red knee is infection unless proven otherwise. Investigate thoroughly, use time-bound protocols, DIAR versus revision, and save implants wherever it's possible. Thank you.